Hello guys, so welcome to this session of Harrison based MCQ discussion where we are going to complete this Harrison chapter alcohol associated liver disease in a fashion that completion of MCQ will lead to completion of the chapter. Okay, so before going into the discussion of the chapter, I would like to discuss about this program or this plan we are going with Harrison revision session, in which our plan is to complete Harrison within 6 month of period. Okay, so first test will start on 12th May and it will continue weekly 3 tests till December of this year. And our plan is to complete the complete Harrison in the form of MCQ discussion within the 6 month. Who are our target? Target is obviously NEET SS exam. NEET SS exam. Then the residents who are busy at their works and do not get enough time to complete Harrison, read the Harrison topic wise. So this is a structured approach which will help them to complete Harrison. Okay, so resident, NEET SS aspirant, NEET SS aspirant, and final year MBBS student can join this program of Harrison revision, and link to join this program is available in the description. Obviously you can join there. Also, if you want to take part in this discussion, so I posted question regarding this topic in our group, this Harrison revision group. Link of this group is also available below the description, so you can find the link to join in this WhatsApp discussion. Okay, so coming to first question regarding this chapter, unhealthy alcohol use in women is defined as. So as you can see here, the reason completely mentioned in this chapter. So unhealthy drink is more than 2 drinks in women per day. So more than 2 drinks per day in female and more than 3 drinks per day in male. Okay. So what is meant by unhealthy drinking? Unhealthy drinking is meant by, in female it is more than 2 drinks, male it is more than 3 drinks. Now there is another term known as binge drinking. Binge drinking is sudden excessive drinking. So why you need to know about binge drinking? It is important because at the stage of binge drinking, blood alcohol concentration rises very rapidly. Okay, it rises very rapidly, and alcohol is metabolized by zero order kinetics at high concentration. So elimination of alcohol from the body is constant. Therefore, in binge drinking, alcohol concentration remains very high at the plasma for prolonged period. So effect due to alcohol will be prolonged and more pronounced in case of binge alcohol drinking. So in female, more than 4 drink per occasion, and in male, more than 5 drink per occasion is considered as binge drinking. Unhealthy is more than 2 in female, more than 3 in male. Remember the formula 2, 3, 4, 5. 2, 3 is unhealthy per day, 4, 5 is unhealthy. That is binge drinking per occasion. Okay. 1 drink is considered as 14 gram of ethanol. All right. Okay. Now, if you look into the next MCQ, so here answer will be unhealthy alcohol use in women is defined as more than 2 drink per day. Option B is correct. Okay. All right. Now coming to the next question. So here a 45-year-old chronic alcoholic is presenting with hepatomegaly. Investigation shows fatty liver. So it may be alcohol-associated steatohepatitis. Which of the following best explain the mechanism of hepatic steatosis in this patient? Okay. So what is the effect of alcohol in the body? Now, if you look into the metabolism, alcohol is primarily metabolized in the liver, in the hepatocytes. So what happens here in a hepatocyte is that alcohol or alcohol is converted into acetaldehyde. Okay, acetaldehyde, and acetaldehyde is converted to acetate. This conversion takes place in the form of dehydrogenase enzyme. So the enzyme name is alcohol dehydrogenase, and acetaldehyde dehydrogenase. The first step is under the effect of CYP2E1. Okay, all right. Now look here, few things you should know, that major pathway goes through this alcohol dehydrogenase pathway, and this CYP21 is involved in chronic alcoholic. So you can remember in case of acute it is alcohol dehydrogenase prominent, in case of chronic it is C4C, it is chronic alcoholic. CYP21 pathway is prominent. Why it is important? Because it is the pathway which activates and result in formation of reactive oxygen species. All right. Okay. So as you can see here, enzyme involved are alcohol dehydrogenase, which is the major pathway, and CYP1, which is induced in chronic alcohol use, resulting in generation of reactive oxygen species. All right. Now, acetaldehyde dehydrogenase detoxifies acetaldehyde. What happens in chronic alcoholic or excessive alcohol use, acetaldehyde production as well as acetate production increases. So as acetaldehyde production increases, it results into acetaldehyde toxicity, and it shows the effect like direct hepatocyte injury, protein adduct formation, DNA damage, and mitochondrial dysfunction. This mitochondrial dysfunction result into release of AHT in the circulation, because AHT is more predominant in mitochondria compared to the cytoplasm. Okay, so AHT increases in circulation for this purpose. Then this reactive oxygen species, which is generated by a CYP2A1 pathway, lead to lipid peroxidation, oxidative stress, and cell death. Now, there is something known as LDH2 deficiency. So, acetaldehyde dehydrogenase deficiency. It is common in Asians. So, what will happen if there is deficiency? There will be decrease in acetaldehyde clearance, and acetaldehyde concentration will increase, resulting in symptom due to acetaldehyde toxicity like flushing, nausea, and tachycardia. All right. Now, here few things you should know. As alcohol is converted to acetaldehyde, enzyme required is dehydrogenase. As this is the enzyme which is required, dehydrogenase enzyme is required. So what happens? What happens at the meantime? NAD is utilized. NAD is utilized, and it results in the production of NADH. So if we look into NADH and NAD ratio, what will happen? NADH will increase and NAD will decrease, and this ratio will increase. What is the net effect of it on metabolism pathway? This step is NADH is required also conversion of pyruvate to lactate. So pyruvate to lactate is converted under presence of lactate dehydrogenase, which also require NADH, So as the ratio of NADH and NADH and NAD increases, so pyruvate to lactate conversion will also increase. So it results into increase in lactate production and lactic acidosis. And total pyruvate number will decrease. So as total pyruvate number will decrease, substrate for gluconeogenesis, pyruvate being a substrate of gluconeogenesis, will also decrease. So therefore, it will lead to fasting, hypoglycemia, one of the predominant symptom in case of alcoholic liver disease. Then what will happen to the fat? So acetate will not go in the production of glucose. In turn, it will go in production of acetyl CoA and fatty acid synthesis because of the change in the ratio. There will be decrease in beta oxidation because of increase in NADH and NAD ratio, which will inhibit the mitochondrial fat oxidation. As a result, fatty acid synthesis increases, and also there is additional effect of epigenetic upregulation of lipogenic genes. Yes, okay. So if we check into this MCQ, so why there is fatty liver? Fatty liver is due to increased NADH and NAD ratio impairing fatty acid oxidation. Okay, so it is the correct answer here. Beta oxidation, what happens to beta oxidation? Beta oxidation is decreased, not increased here. Triglyceride synthesis will increase. Okay, as fatty acid synthesis is increasing, triglyceride synthesis will increase in this case. Reduced fatty acid metabolism from the adipose tissue, no, fatty acid mobilization will increase. Okay, all right. So coming to the next question, a 32-year-old male presenting with flushing, nausea, and palpitation shortly after consuming small amount of alcohol. He reports similar symptoms since adolescence. So something, it is childhood onset disease, and there is flushing, nausea, and palpitation shortly after consuming small amount of alcohol. Which disease we are talking about? We are talking about the disease in which there is acetaldehyde dehydrogenase type 2 deficiency. Okay, you can look in the note. So there is condition in LDH2 deficiency is present. It is a genetic disease common in Asians. Common in Asians. What is the net effect? Net effect is the flushing, nausea, and tachycardia on alcohol use. Why? So because on alcohol use there is increase in production of acetaldehyde, and acetaldehyde is not converted into acetate. So it is not reduced into acetate. What is the net result? Increase in acetaldehyde, and increase in acetaldehyde rate induced toxicity. So what are the symptoms? Symptoms are flushing, nausea, and tachycardia. All right. Okay. So this is about deficiency of acetaldehyde dehydrogenase. Option C is the correct answer. All right. Okay. What happens in increased CYP2A1 activity? So, due to this activity, there is increased generation of reactive oxygen species seen in chronic alcoholics. Which drinking pattern increases risk of alcohol-induced liver injury? So, obviously, there are two reasons, two pattern which increases the risk. One is binge alcohol drinking. Another is drinking without meal or at empty stomach. Why so? Why so? So binge alcohol drinking is associated with increase in blood alcohol concentration, and as it follows zero order kinetics, so elimination is constant. So amount of plasma concentration remains higher for prolonged period of time. So acetaldehyde and acetate production increases in binge alcohol drinking. What happens when it is drinking is done without meals and with meals? With meals, in presence of meal, gastric emptying time increases. Okay, gastric empty time increases, whereas in absence of it there is no decrease in the gastric empty time. So most of the alcohol get absorbed from the duodenum into the circulation, resulting into increase in blood alcohol concentration above the certain threshold. But with increase in gastric emptying time, so absorption is slowed down. So as absorption is slowed down, so amount of alcohol in the circulation reduces. Therefore, with meal, the risk of alcohol-induced injury is less. It obviously increases with when it is drinking is done without milk. Okay, and at empty stomach, risk increases. Most important genetic polymorphism associated with ALD progression. So answer is P and PLA3. It is true. Whereas HNF2 alpha seen, HNF2 alpha seen in maturity onset diabetes in young, then mainly in MODY 1 and 3. PTPN22 is seen in autoimmune diseases like type 1 diabetes mellitus, or in case of rheumatoid arthritis. ApoE gene is associated with Alzheimer's disease. Okay. So what are the other genetic polymorphism which is associated with ALD progression? So you can see here from the notes. So gene increasing the risks are PNPLA3, MBOT7, and TM6SF2. How do you remember? Remember the PMT increases risks. And genetic protective are AHF. AHF is HHD17B3 and FAF2. So these are the two protective factors, AHF, and increasing risks are PMT. Okay, all right. Now coming to the next question. So 48-year-old male with chronic alcohol intake presenting with rapid onset jaundice for 10 days. He has been consuming 70 gram of per day alcohol. So it is a very high dose of alcohol intake is there. Chronic alcoholic, but symptom is acute. So abstinence is not there. There is fever, tender hepatomegaly, and mild ascites. All of this pointing towards alcohol-induced liver injury. AST is raised, ALT is raised, AST-ALT ratio is 2, so it is also raised. Bilirubin is 5 times normal. INR is mildly elevated. So, which of the following finding, if present, would mostly strongly support the diagnosis of alcohol-associated hepatitis over decompensated cirrhosis? Okay, all of this pattern can be seen in cirrhosis too, but it is an acute presentation. It's going to alcohol-induced hepatitis, but still see into the options. So, if you see the difference between these two, so cirrhosis versus alcoholic hepatitis, a very important table to differentiate among them. Look, alcohol is acute onset, cirrhosis is chronic. Bilirubin will be raised in both of the cases, but it will be predominantly more than 3. Fixed increase will be seen in alcoholic hepatitis. AST-ALT ratio increases in both, although the reason is different. In cirrhosis, there is no liver cell at all present. So, as liver cell is not present there, ALT will decrease. ALT will decrease. Why AST increases? Because AST has other liver sources like muscle, heart, cardiac muscle, everything. So, That's why AST-ALT ratio increases in cirrhosis. What happens in alcoholic hepatitis? In alcoholic hepatitis, as acetaldehyde level increases, it impairs with the metabolism of pyridoxal phosphate. Pyridoxal phosphate. This pyridoxal phosphate is essential for all the transaminases enzyme, including AST and ALT, but it is more importantly required for ALT. So as PLP decreases, ALT level also decreases in case of alcoholic hepatitis. This is number one point. Another point is that in alcoholic hepatitis, mitochondrial injury is seen. Due to mitochondrial injury, AST decides more in the mitochondria, ALT decides in the cytosol. Due to this mitochondrial injury, AST is also released in the circulation. Okay. So if you see the half-life of ALT is more than the AST. That's why amount of ALT which remains in the circulation is more than the AST, and clearance is also impaired. That's why it is more than 1.5 times in alcoholic hepatitis and more than 1 in case of cirrhosis. Now, if you look at the AST level will be less than 300 and less than 400 in case of alcoholic hepatitis. SIRS criteria is more common in alcoholic hepatitis and it is rare in cirrhosis. Tenderness of liver will be more common in alcoholic hepatitis. Okay, so as you can see here, among this, presence of SIRS criteria is goes to a diagnosis of alcohol-associated hepatitis. Thrombocytopenia will be seen in both the cases. It is seen in cirrhosis mainly because of splenomegaly as well as decrease in TPO. So AG ratio reversal is seen in case of cirrhosis, splenomegaly in ultrasound because of the portal hypertension is seen in case of cirrhotic patient. All right, in case of decompensated cirrhosis. Coming to the next question, 50-year-old male with heavy alcohol intake presents with jaundice and malaise. Lab shows AST, ALT elevated, so AST is elevated, ALT is elevated. But if you check into ratio, AST ALT ratio is more than 2.4, bilirubin is 6. So these are pointing towards alcoholic hepatitis. All right, alcoholic hepatitis. Ultrasound shows fatty liver without biliary obstruction. That is usually the reason why we go for ultrasound in case of alcoholic hepatitis, because bilirubin is 6 and it is often direct more than indirect. That's why to rule out biliary obstruction, we go for ultrasound in such cases. Which of the following is the next best step to confirm the diagnosis? So you can see here, issue with this lab parameter is that AST is more than 480. So in case of alcoholic hepatitis, AST is elevated, but it never rises above 400. It usually stays less than 400. When it is above 400, you need to rule out the alternative diagnosis. What are the alternative diagnoses? Like drug-induced liver injury, autoimmune hepatitis, or ischemic hepatitis. So liver biopsy is rarely done. Liver biopsy is rarely done in case of suspected alcohol-induced liver injury, until and unless there is atypical lab value. What are the atypical lab value? AST very, very less or AST very, very high. That is more than 400. Or AST-ALT ratio less than 1.5. Okay, so when the ratio is not followed or AST is very less or more than 400, alcohol history is uncertain, and you suspect it to drug-induced or autoimmune hepatitis or ischemic hepatitis, in such cases, you need to go for liver biopsy. So AST here is coming more than 400. So this is suspicious lab value which is not fitting towards alcohol-induced liver injury. That's why in such cases, you need to go for transjugular liver biopsy. D is the correct answer. Start treatment for alcohol-associated hepatitis directly. No, you will not directly start, because treatment here is obviously the steroid therapy and hydrosteroid therapy. You need obviously to rule out the other causes before starting the person on steroid. All right. Then perform transient elastography. What will it tell? It will only tell about fibrosis. So nothing it helps in this case. Also, ultrasound is showing fatty liver. It is also not specific of cirrhotic changes or anything. Calculate FIB4. FIB4 is OPT basis method to rule out for other method approach for fatty liver disease. Okay. So here answer is transjugular liver biopsy. Now coming to MATRIX discrimination function more than 32, what does it indicate? So as you can see from the note, so this is a chart in the Harrison. It shows you what is the approach you need to go for when you suspect alcohol-associated hepatitis. First of all, when there is clinical diagnosis with lab finding, until and unless there is no confounding factor, obviously in confounding factor you go for transjugular liver biopsy. First step is to check for mid-range discrimination factor or MELD score. Okay, so how do you go for it? What are the points in mid-range discrimination factor? Mid-range discrimination is calculated by 4.6 multiplied by prothrombin time of patient minus prothrombin time of control plus bilirubin. Okay, if it is more than 32, it suggests to be severe alcohol hepatitis. Now, if MELD score, how is MELD score calculated? It is calculated based on creatinine, bilirubin, and INI. Okay, CBI, creatinine, bilirubin, and INI. If MELD score is more than 20, it is also suggested to be severe alcohol hepatitis. So check for MDF and MELD score. Any one of them more than 32 or 20, or MDF less than 32, MELD less than 20 is moderate. In case of moderate, alcohol abstinence is advised and nutritional support is given. Only alcohol abstinence has this proven role compared to any other drug because it reverses the disease in such cases. Now, when severe disease, you need to start oral prednisolone. Oral prednisolone around 40 milligram per day, and if unable to take, go for methylprednisolone. At the meantime, obviously, you need to rule out contraindication for corticosteroid. In contraindication for corticosteroid, if eligible, faster phase, obviously liver transplant. If not eligible in such cases, you can start supportive and palliative care like pentoxifylline. Usually in chronic renal failure with creatinine more than 3, pentoxifylline is chosen. Now, when you start on steroid, next step is to continue steroid for 7 days and monitor. Monitor with Lille score. What are the component of Lille score? Remember, component of Lille score are A, B, C. Okay. So, what are the component according to this ABC score? A is age and albumin. B is bilirubin change. C is creatine. Okay. Now, based on this Hepc model with Lille score, check Lille score. If it is less than 4.5, so it suggests there is improvement with steroid therapy. So, continue steroid for 28 days. And if Lille score is coming more than 0.45, at this point, stop prednisolone. Stop prednisolone and consider for liver transplant therapy. All right. Now, if you see MADRS discrimination function more than 32, what does it represent? It represents severe. So, option C is correct answer. Which of the following is contraindication for glucocorticoid? So, steroid therapy is usually not done in case of uncontrolled infection, in case of AKI renal dysfunction, ongoing renal dysfunction, active GA bleed, viral hepatitis, TB, HIV, shock, and multi-organ failure. These are the usual contraindications for steroid therapy. In such cases, control the disease, then start on steroid. All right. So here, as you can see here, so which of the following is contraindication? Bilirubin more than 2? No, it is not. INR elevation? No. AST/ALT? No. Even it is an indication to consider this to be alcohol-induced liver injury. And controlled infection? Yes, it is a big contraindication for starting the patient on steroid. A 48-year-old alcoholic with suspected alcoholic hepatitis. So here MDF is coming to be 34. So what is meant by MDF? MDF means MADRS discrimination factor. So what does it suggest? It suggests a severe form of disease. So what you need to do here? So when MDF is coming to be more than 32, you need to start on steroid. But here as you can see there is active upper GI bleed. So in presence of active upper GI bleed, you do not directly start on steroid. At this point, control the disease, control the GI bleed, and then only you decide to start on steroid. Okay, so here wait before starting the steroid. So patient with severe alcohol associated hepatitis is started on prednisolone. After 7 days, Lille score is coming to be 0.52. So what you do at this point? So when Lille score is coming to be 0.72, 0.52, so it is more than the score that is suspected. So less than 0.45 of Lille score means good control with the disease. You need to continue steroid for 28 days at the same dose. When score is coming more than 0.45, what you need to do? You need to stop prednisolone and consider the patient for liver transplant. Okay, all right. So That's all regarding the MCQ discussion. This is the short topic through which we have completed the chapter on those alcohol induced liver injury. And similarly, we are going to discuss more of the important MCQs, and it will be designed in such a fashion that completion of MCQ will result into completion of the topic in our program of Harrison revision. Okay, I hope most of you would like this session and will join the sessions. Thank you.